All right, so in clinical microbiology, you know there are those bugs that just love to fly under the radar until, bam, they cause a serious problem. Today, we're putting one of those sneaky pathogens right under the microscope, Mycobacteroides chelonae. And trust me, this isn't just a challenge for us at the lab bench. It's a real threat that can lurk in hospital water systems and pop up in postoperative patients.
So, first things first. You've probably noticed Mycobacterium chelonae got a new name. Big deal, right? A bunch of taxonomists just shuffling the deck? Well, actually, yeah, it's a huge deal. And we're about to dig into exactly why this name change is way more than just semantics. It has direct, real-world consequences for how we diagnose, how we treat, and ultimately how we keep patients safe.
So, this is The Explainer. And for today's breakdown, we've built everything on a comprehensive monograph on Mycobacteroides chelonae. This was all compiled using a Gemini deep search to pull in the latest global data. And if you want to see all the papers and get into the nitty-gritty, the full notebook document with all the sources is available for you to check out.
Okay, so here's our roadmap. We're going to cover 5 key areas. We'll start with why it was reclassified, then walk through the clinical syndromes to watch out for, dive into the diagnostic pathway in the lab, tackle the tricky world of susceptibility and resistance, and finally wrap it up with treatment and infection control. All right, let's jump right in with Section 1, the reclassified pathogen. And believe me, this is about a whole lot more than just updating a textbook entry. So what's the story here? Well, back in 2018, a really important study by Gupta and his colleagues used phylogenomics. Basically, they looked at the entire genome to build a family tree. And what they found was that the old Mycobacterium genus was, well, a bit of a mess. It was polyphyletic, meaning it wasn't one single, neat family. This new robust evidence made it clear that chelonae and its relatives needed their own genus, and so Mycobacteroides was born. Okay, but why does a name change really matter in your lab day to day? Well, it's a bigger headache than you might think. For one, the name Mycobacterium chelonae is everywhere. In decades of literature, in clinicians' minds, a new name on a report can cause some serious confusion. It means we all have to update our laboratory information systems, but most importantly, it's a patient safety issue. It forces us to be crystal clear about distinguishing it from the Mycobacterium abscessus group, because their drug susceptibilities are worlds apart. Getting this wrong is a major risk. And that leads us perfectly into the clinic. Section 2, Clinical Syndromes and Risks. Think of this as your field guide for when this organism should be way up on your list of suspects. At its heart, Mycobacteroides chelonae is a classic opportunist that attacks the skin. You should be thinking about it anytime you see a chronic skin lesion that just won't heal, especially after something breached that skin barrier. And I mean anything from a major surgery to something as simple as an injection, a tattoo, or even a pedicure. The classic calling card? Look for that sporotrichoid pattern of nodules tracking up a lymphatic vessel. The source is almost always contaminated water, and remember, you can't get it from another person. And of course, in an immunocompromised patient, a local problem can become a widespread disaster. Now, here is a huge point of distinction, so I really want you to lock this in. If you isolate a rapidly growing mycobacterium from a lung sample, your brain probably jumps straight to Mycobacterium abscessus. But if that ID comes back as Mycobacteroides chelonae, hit the brakes. True lung disease from this bug is incredibly rare. It's far more likely to be simple colonization. This is where you absolutely have to stick to the strict ATS/IDSA diagnostic criteria to avoid putting a patient on months of unnecessary toxic antibiotics. Okay, let's head into the lab. Section 3, the diagnostic pathway. So how do we actually track down this elusive bug and get a rock-solid ID? We talk a lot about high-tech sequencing and fancy machines, but sometimes you just can't beat a well-trained pair of eyes at the microscope. It all starts right here. An astute microbiologist looking at a gram stain from one of these stubborn wounds can literally be the difference maker, slashing the time to diagnosis. So here's the typical workflow. On the gram stain, this thing is tricky. It has a really lipid-rich cell wall, so it stains poorly. You're looking for these faint, beaded, almost ghost-like bacilli that are super easy to miss. For culture, temperature is everything. It likes it a bit cooler, so you need to incubate at 30 to 32 degrees Celsius for good growth. Then, once you've got it growing, molecular ID is not optional. It's essential. Okay, and this next part is a non-negotiable take-home message for every modern microlab. Our usual go-to for ID 16S rRNA sequencing is just not reliable here. The sequence is way too similar to the Mycobacterium abscessus group to tell them apart. It's not good enough. For a definitive, clinically actionable ID that you can bet on, you absolutely must sequence a housekeeping gene like RPOB or HSP65. That is the gold standard, full stop.
Now for Section 4, susceptibility and evolving resistance. And this is where the story gets really interesting and, frankly, a bit concerning. The landscape here is definitely shifting under our feet.
So even before you get your sequencing results back, you can get some really strong clues right from the bench. Mycobacteroides chelonae is positive for citrate utilization, which is helpful. But the real giveaway is its intrinsic resistance pattern. It is naturally resistant to sulfoxetine and susceptible to tobramycin. And what's so cool about that? It's the exact opposite of Mycobacterium abscessus. It's a beautiful, powerful way to help differentiate them.
And here it is, the game changer, the critical update. For years, we kind of took for granted that this organism was reliably susceptible to macrolides like clarithromycin. Well, throw that assumption out the window. A totally new resistance gene, ERM55, has been found. On a plasmid, that means this resistance can be acquired and passed around between bacteria. This discovery fundamentally changes how we have to approach susceptibility testing.
Now, a quick but really important note on reporting. As of right now, UCAS hasn't given us specific clinical breakpoints for Mycobacteroides chelonae. So what does that mean for us in the lab? It means we can't just report S, I, or R. We have to report the actual quantitative MIC value and then work closely with the infectious disease docs and pharmacists to interpret it, using things like epidemiological cutoff values and published clinical data to guide the treatment plan. This brings us to our final and maybe most important section, treatment and infection control. It's about how we help the patient in front of us and just as critically, how we make sure this doesn't happen to anyone else. So when we look at treatment, let's take the Netherlands as an example. There aren't actually any formal national guidelines, so practice really just aligns with the international consensus. For simple skin infection, macrolide monotherapy might do the trick. But for anything severe involving skin or bone, you're looking at long-term combination therapy, a macrolide plus something like tobramycin or imipenem. But let me be perfectly clear, medication alone will not cut it. Surgical debridement to remove the infected tissue is absolutely critical for a cure. This is a surgical disease, first and foremost. Now, when we're treating kids, the principles are the same, but our level of vigilance has to be dialed way up. All the dosing is based on weight, and you have to monitor closely for toxicity. For tobramycin, that means doing therapeutic drug monitoring and regular hearing tests. For linezolid, you need weekly blood counts to watch for bone marrow suppression. And with doxycycline, it's the usual warning, be cautious in kids under 8 because of potential tooth staining. So how do we prevent these infections in the first place? Look, it all boils down to one word, water. Full stop. Tap water is the enemy here. It should never be used for wound irrigation or rinsing sterile medical devices. We have to use disinfectants that are proven to kill mycobacteria. Glutaraldehyde, for example, is notoriously unreliable against these guys, and maybe the most overlooked step. After you disinfect something, the final rinse must be with sterile water, not tap water, or you've just recontaminated the whole thing. And I want to leave you with a really simple, powerful number. 1. That's it. 1. Do not wait for a pattern. Do not wait for case number 2. A single healthcare-associated infection with Mycobacteroides chelonae must be treated as a sentinel event. It should immediately trigger a full-on outbreak investigation to find the source.
And that kind of leaves us with a big forward-looking question, doesn't it? The emergence of plasmid-mediated macrolide resistance was a total curveball that nobody saw coming. It really makes you wonder, what's next? What's the next diagnostic headache or therapeutic nightmare this incredibly adaptive and persistent pathogen has in store for us?
And that's our deep dive on Mycobacteroides chelonae. I really hope you found this explainer helpful. If you did, do us a favor and subscribe for more insights from the front lines of clinical microbiology. And hey, we genuinely want to hear from you. Leave your questions, your own lab experiences with this bug, any feedback at all, right there in the comments below. Thanks so much for joining us.